But first of all, thanks for having me. I'm sorry I couldn't be there in person, but I'm going to talk about biologics for the spine, which I think is very, very important. Although I think it's something that's quite overlooked, and it's something that perhaps we don't think too much about. These are my disclosures, which should not affect anything I'm going to speak to you about today. And so what's kind of cool about this talk is that I can give you the same slides that I used 20 years ago when I was talking about biologics. But what's kind of not so cool is that I'm giving you the same slides, meaning we're still trying to talk about the same sort of demand for evidence from biologics that we were 20 years ago. And unfortunately, not a lot has changed. And when I say not a lot has changed, it's the surgeons. We don't really think about the biologics we use as much. We're so focused on the hardware, and we aren't demanding that the biologics have a lot of evidence behind them. And that was a problem that we had 20 years ago. And I think it's even more of a problem today. And it's just something that people don't think about. My hope is that your generation in the audience today will hopefully demand that there be some more evidence. And so what I want to talk about first is just autograft. I mean, I think it's the gold standard. When people talk about any of these substitutes, we always compare it to autograft. The problem with autograft is that I don't use it that much anymore. And I doubt whether many of the faculty here use it that much anymore. If you go internationally, it's still used a lot, and it's kind of a lost art form because a lot of people could probably take a bone graft, but a lot of people probably nowadays couldn't do it very well. If you asked our fellows to take one, they could probably do it, but they wouldn't be able to do it well. And there's some intricacies about it. And if you don't do it in the right way, it can cause a lot of pain. And that's one of the reasons we stopped doing it. And I would put it to you when I say people don't care as much about biologics. I mean, when you think about it, you probably haven't done a structural graft for the cervical spine or lumbar spine or for the spine in a long time. And arguably, it's the one thing. I mean, you're going to go in the lab, you're probably not going to practice doing a bone graft. Not that anyone would want to, but it's the one thing you probably won't do as much. You're going to do a lot of osteotomies. You're going to place a ton of screws in your career, but you may be able to count on one hand how many times you take an autograft. And it just depends. If you have a patient from Japan, culturally, they won't allow allograft, right? So you may be forced to do an autograft. The last autograft I did for the cervical spine was a football player at UCLA who had talked to Peyton Manning, who had gone through, as we know, several cervical surgeries and had a non-union and only healed once he had an autograft. And so he demanded that I use an autograft. Based on talking to him for a cervical spine. So there are situations where you need it. But now we have a ton of products out there. We don't really probably think as much about it when we choose it. The only thing I would say is that when you're using a graft, please have some evidence behind it, have some rationale behind it. The rationale shouldn't be, well, I needed some graft material and the rep for the hardware was in the room, and so I decided to use his stuff. Just make sure that there's some evidence behind it. As far as the graft properties, I think we all know these are the sort of the triad. You can't, there's many products out there that are osteoconductive, there's cells, and there's some osteoinduction like BMP. Oftentimes you have to use combinations, like you can't put cells in there alone because the cells will kind of wash out, so you need some type of carrier. But I think it's important to look at the data out there and understand you can have a great graft, like here's a BMP in an animal model, or even if you use it in the human off-label posterolaterally, that even if you just use the collagen sponge and you put it in posterolaterally, the muscles are going to compress it, so it's not going to heal, right? And so if you use it with a structural graft, then it could heal. And so it's not just having the right element, but having the right carrier. And when you look at the non-human primate data that went into the FDA approval for the original BMP, it's not so much important that you see which carrier is the best, but it's important to understand that here's a study in non-human primates where they use 3 different carriers. And one of the carriers used a fraction of the dose, less than a third than the others. And so when we look at moving into the future, if we're going to use something like a growth factor or something like that, if we use the right carrier, we may not need to use as much of a dose, and we may not have the complications. And this is a study we published in a rat model a long time ago. And the real thing to understand is that if you take a dose of BMP in a rat that only heals 40% of the time, but all you do is change the carrier, you get 100% fusion. And then you take an even smaller dose in a rat model that only heals 10% of the time in a rat, and you change the carrier with a small, minute dose, you can get 100% fusion. So what that tells me is that if we could get the right carrier with the right biologic, you can probably minimize the dose. But the problem is that's never going to happen, because every time you change the carrier, you have to go through an FDA trial. So it's just really complicated. And right now, people are selling carriers for just as much almost as the BMP itself. And so people are looking to make money off that. The other thing to understand is that when we put BMP in at the time of surgery, it's the highest dose and then it trails off. But when you look at the actual graph, if you take away the red arrows, that's Scott Bowden's model in a rabbit posterior lateral fusion, looking at the BMPs that normally interact. And the most important thing to understand is that normally BMP2 is maximal 3 to 4 weeks after the time of surgery. And so maybe we're artificially driving this fusion process by putting a huge dose in at the beginning and having it trail off. Whereas if there's a time release where we could present the BMP in the environment maybe later, then it may be more effective. And so when you look at the future on what variables we can change, it's not so much having a different like growth factor combined with cells, different carrier, but maybe changing the timing, time release, nanoparticles, things like that. So the other problem is that when you look at the products that are out there, they're basically tested in a rat model. And when you look at this hierarchy, when you go from a lower animal to a rat all the way to a human, it takes a higher dose and a longer period of time to heal. And so when you see the data that your rep brings you when you're using your bone graft of choice, whether it's a DBM or something like that, and they say, well, it heals in animal studies, that may not mean that it's going to heal in humans. And especially there's probably a hierarchy, right? At the very top, you have animal studies, pediatric fractures, and you go down the list. At the very bottom, you've got very challenging environments where it's not as biologically active. And in those situations, you probably need more bone graft material or something a little bit stronger. And so we have a hierarchy of patients. We know that pediatric patients are going to heal pretty well, but you go down the hierarchy and you get back to older patients with rheumatoid arthritis and they have multiple revisions. That's a very challenging environment. So you also have to pick the right biologic. You may not need something like a huge BMP growth factor in a young healthy patient, but someone who's older, revision, you might need that. You also need to understand where you're going to put it in the spine. Is it going to be something like a multi-level fusion for a deformity, or is it a single level fusion? But this is the way most companies test their product. They put it in a muscle pouch and they say it forms a little nodule of bone. And they say that that means it's osteoinductive. And technically with the FDA, that does mean it's osteoinductive. Doesn't mean that it's going to work in your patient. The other thing to understand is that the environment makes a difference. We talked a little bit about challenging environments, but if you have like a long bone fracture and you put it together, it's probably going to heal because bone is used to being formed. I mean, you've got an area where it's broken, but bone is normally there. When you talk about a posterior lateral fusion, bone is not normally there. So the spine is a challenging environment. Even in the interbody space, you normally don't form bone in the disc space. And just so you understand that it's not an environment that's conducive to bone formation. And so that's something to understand. I kind of want to finish talking about some of the controversies. We all know that there are controversies with the BMPs, and we know that there are potential complications. And the Spine Journal came out probably a decade ago talking about underreported complications. So in my mind, the biggest controversy in biologics is not the BMP controversy. For me, the biggest controversy in biologics is the fact that you've got something like BMP that has a tremendous amount of data. And the biggest controversy is the fact that a lot of the other companies have jumped on the bandwagon and used your fear of potential complications for BMP to promote their products that have no evidence behind them and whatsoever that they work at all. And so for me, the biggest controversy that existed 20 years ago in biologics is the one that still exists today. The fact that all the products you're using, the vast majority of the ones that you are using and you're going to use, they have no data whatsoever to support that they work. There's no data to support that you should be using it in your patients. And you don't really make a choice based on the evidence. And that's the biggest controversy in my mind. When we look at all the different biologic products out there, you can choose from many of them, and you're going to get these great slideshows talking about how their product is great. And it's a huge market. It's billions of dollars, right? And so when you make a choice based on the evidence, there's a hierarchy of the evidence. There's scientific data all the way down to no science. And when you look at some of the biologics, there's really no science behind it. And when you look at, there's a lot of studies out there showing the variability of the different amounts of potencies amongst the same products between different lot numbers because they're made from humans, right? And so just in my career, I've seen so many controversies. I remember early on, I don't think anyone uses platelet gels, but even when the studies in animals showed that these inhibited bone healing, the companies were still selling them and the surgeons were still using them. When you look at DBMs, we talked about all the variability. We talked about some of them have no evidence. People are still using them and they don't demand the evidence. And then the whole genre of DBM plus cells, when that came out, I remember going to the meeting and talking to some of the companies, and I said, well, it's great you're selling it. Where's your data? And I remember their answer to me was, we don't have any. We'd love to get some. So this whole class of DBMs with cells, they started selling it and they didn't have a speck of data showing that it worked at all or it added anything. And if you look, they charged a huge amount and they still charge a huge amount. And I won't go over the studies, but the studies show that this is no better than the DBM that it provides. And so there's no justification for you guys to be using allograft plus cells with the added cost. There's no benefit to the addition of the cells. And that's been shown in all the studies so far. There are very few studies, and yet no one knows about that. For me, that's the biggest controversy in biologics. No one knows what the data shows. And even when the data shows it's negative, it doesn't stop us as surgeons from using it. And we don't demand that they're products. This is a study I published two decades ago, and there's 3 products that are still on the market today. And in a rat fusion, one fused 60% of the time, one fused 0% of the time, and one fused 80% of the time. They're all 3 still being sold. Does anyone have an idea which one sells the most?
Center.
I can tell you that it has no basis on this. The company that sells the product that has the largest sales force sells the most, and the company that has the second largest sales force sells the next most, and the company that has the third largest sales force sells the third most. And it has no bearing on the evidence and things like that. And that's what we're trying to stamp out here, because the real controversy in my mind is the fact that there are day-to-day products we're using all the time that have no evidence behind them. And when you look at this, is this an ethical problem? Because where do these allograft products come from? They come from people, right? These are people that have died and they're donating their bone, and we're taking their bone. When I say we, I guess you're saying society or companies take their bone that they've donated from dead people and they make these allograft products. And if we're going to use these products, I think we have sort of at least an ethical dedication, or we should be at least demanding that these products show some evidence. You know, the last thing I want to make up time. So I will say this, I see the controversy in stem cells continuing, because how many times do you see these advertisements for stem cells, for disc regeneration? There's all this stuff on the internet about stem cells, and at least in the spine, there's very little evidence to show that they provide any evidence whatsoever. And this is these patients that are going spine surgery, very, very sensitive group of people. My experience, when I was a resident at UCLA, there's a dermatologist that had an address in the UCLA Medical Plaza, and they advertised something called Disc Cure. It was Enbrel combined with a patented mixture, which is what they used to treat rheumatoid arthritis. And they made people paid cash, and people jumped all over this. They advertised it as an alternative to fusion. And I remember being a resident, being in the spine office with late Dr. Dawson and Dr. Delamarter, and patients would come in, and I'd say 80% of them had tried this, had paid cash, and it hadn't worked. Eventually, there was a class action lawsuit against them, and there's a payout they paid to NAS, and there's about $1 million sitting in the NAS research budget. If anyone wants to do any research based on this, then that money is supposed to be used for this, but no one's doing any research based on that. But if you want a research grant, go ahead and reply to NAS, and there's all this money sitting there for you to do it. The second thing experience is that everyone knows late Kobe Bryant. There was a stem cell injection created by a German company, and this German guy was in a lab when I was in med school in Pittsburgh back in the 90s. He was there working in the same lab. The bottom line is they have a stem cell injection for the spine. There's really no evidence that it worked. They approached us and they wanted us to do it at USC. Our lawyer said, we will do it, but we want to gather the data. And they said no. And so this company does not want the data. I can tell you there's a sports medicine attending who lives in Taiwan. He trained at UCLA when I was a resident there. He's the only one in Asia that can administer this stem cell injection, and people are flying in all over the world to Taiwan to get it. for all over Asia, and he's making a ton of money off this. And again, there's no data to support that it works, and the patients don't require the data. And I just see this biologics controversy just kind of going. I will say that the last thing I want to say, well, the last two things I want to say is, number one, when you look at the studies on us assessing biologics infusion, a lot of times I don't know how you can assess this, so be questionable. I don't know if that's fused or not. People say it's fused. People say, oh, I use titanium cages and it's fused, but you have to understand the thing. But the last thing I want to hit you with is that with one of the knowledge forums with AO Spine, we're leading this bone classification, which is basically a call for evidence. And what we're basically doing is we came up with a classification for biologics that would understand the evidence supporting it. And so you could take any product that's out there and understand where it rates as far as the evidence to support its efficacy in the studies that have been done. It basically has 3 different levels, and I won't bore you with it, but I do think this is the future, right? We have classification systems for fractures, cervical fractures, thoracolumbar fractures, things like this. Why not have a classification system for biologics so we can compare the biologics, compare the evidence between the different products, because right now there's nothing out there. So in summary, thank you for having me. These are just some of my thoughts on biologics. I would just encourage you to think a little bit more about it when you use these products. Thank you very much.
Really big picture. So thank you for recovering so well and joining us. Super important lecture yet again. To rate evidence, companies are not lame. They give us a lot of picture materials. In full disclosure, I'm co-chair of the Osteobiologics Committee of the Providence St. Joseph system. So I get inundated with that material all the time and have to make difficult decisions. But the companies do give you a lot of glossy so-called research and evidence. Tell us what, in your experience, the best animal model is when we are supposed to rate fusions or quality of bone grafts. What's the best animal model?
Yeah, it's a hard question. I mean, obviously, the one that's more like the humans is the non-human primates. They're very expensive. You can't do very many. They're just so expensive. So if you do a study, it's going to have like five or 7. Whereas if you do something like a rat, then you can do millions, right? Because they're so inexpensive. I will say that the standard doesn't apply for anything, but I will say is to understand the different models. Like sheep heal everything. So someone comes to you and said, we have sheep data showing this healed. I mean, they heal everything. So that shouldn't impress you, right? For me, it's a stringent model. But the other thing that impresses me is the relative biologics. Like if you take a rat model and you put in something like a graft on or something like that, understand how something else fuses in that same model compared to that as a standard. So sometimes it's not like, oh, this works great in rats, it's going to work in humans, but it's like, this is something that's out there, and this is something that fuses better than that or fuses less than that.
So then, oh, sorry, Louis has a question. 1 second, Louis, let's get you a big microphone.
Hi, Jeff.
Hey.
Great to hear your talk. I'm a skeptic about grafts in general. So I loved your talk. And in my opinion, your talk has one thing that is very, very important is the environment of the fusion. Because all the controversies 20 years to today were on posterolateral fusions, where is normally not bone area for fusions, right? Isn't very different when you look to a construction like a lateral procedure that is my environment, that is anchored and stable by ligaments and posture, hardware, and then you drop a transparent cage and you look to the bone all along. This, in my opinion, is a good model, human model, right? And if I look to this during my 20 years of experience, I would say that is no graft that's better than the other graft. It is the stabilization factor that matters. If I make a stable construction solid and anchor in the best bone, why I care what kind of graft is inside my cage. It's like getting old. You get old, you don't move, and you have an autofusion. What kind of graft is that? Is age?
So let me abstract that question to one thing. That's one of my favorite new neologisms, and that is, do we still need an actual bony fusion, or have we arrived where we are okay with a metalusion? Something where we have a bonding of hardware. I think that's how I abstract Lewis's question. So do we still need a fusion? Is this an anachronism?
Well, quick answers. Number one, I think if you're trying to do a fusion, you still want to get a fusion. I think we would argue that if you get a fusion, you're more likely to have an outcome. You don't need a solid fusion to have a good outcome, and everyone's a little bit different. Number two, I would totally agree with the environment. You may not need like a BMP in an environment that's great in interbody space. Posterolaterally, you might need it. You may not need it in a younger patient that's healthy, but you may need it in an older patient that's on like rheumatoid arthritis medications. It's a pretty challenging environment. So I think it's great you're thinking that way. The only thing I would just want to extend to the audience there is that think a little bit more about the biologics that you are going to use, because you're probably going to use something. And I think if we as surgeons demand that there be some evidence, we start making a little bit of decisions on evidence, and they won't come out with these products unless there's a little bit of evidence behind it. And I think we owe that to the people that are donating their bones.
I think that's a hugely important perspective. Rapid fire questions, since we have your brain power here, but we are stressed for time also. So rapid fire answers also, hopefully. Board answer, in an adult, we have David Skaggs in the front row here. How long does it take to get a lumbar fusion? What's the time frame of fusion versus pseudoarthrosis or delayed union? Can you give us some basic Gestalt numbers?
I think it's different, everyone. I think it takes a year. For me, if they're not healed at 1 year, I call it a non-union. If they're not healed at 6 months, I don't think that I could say it's a non-union just yet.
Pediatric perspective, David Skaggs, what do you tell patients in terms of non-union versus delayed union?
For the big scoliosis cases, I tell everyone they can go back to full sports at 3 months, and there's no way to know if they're fusing. That seems to work.
Okay, 3 months. So there's a huge perspective change from having a viable biologic environment to the aging senescent spine. Second rapid fire question, BMP and healing impaired patients that have a problem systemically, like oncologic indications, absolute no-go, or can we consider BMP in an off-label fashion, of course, for oncologic indication patients?
I personally still wouldn't recommend it. I mean, if you look at the studies, some of the BMPs with different tumors actually inhibit tumor and others promote. And so the key is you're not sure which one you're going to be doing. So I think it's still a bit risky.
And then final learning points, you said it earlier, I just want to drive this home with our audience. Certain carrier proteins, are they equivalent to BMP in terms of its ability to form bone or not? I'm not going to mention the manufacturer, but I think we all know who I'm talking about.
You're talking about the non-BMPs out there, the different products?
Proteins, yeah.
Well, see, that's the problem out there. There are a lot of companies have come up with these bone graft substitutes or products that are almost the same price, if not the same price as the BMP, and there's no evidence to show that they help. I will say that, there's a new BMP's off patent right now, and there's a BMP2 that's coming out of Korea that we might be using, that they're using in Korea right now. And so there's a whole lot out there on the horizon with the BMPs and maybe even some other factors.
Final question, promise. Structural allograft, let's say front of the thoracic spine corpectomy or cervical 1 or 2 level corpectomy. What's your ideal anterior graft? All things being equal in terms of biology, stability, etc., neurologic indication. A structural allograft from a quality source, a PEEK cage, so a polyethylene ketone device, or a titanium spacer. What's your ideal graft for an anterior structural strap? I have all the easy questions.
It's not an easy question because for me, I like the expandable cages because if I'm sneaking something behind the nerves or around the nerves, I want something I can expand. And so I typically will use something that's expansile, whether it's a PEEK or a titanium cage. Biologically, I trained with the late Henry Bowman, and for structural grafts, cervical spine, we took autograft fibula. The healing rate was really high, but boy, I don't think I could do that these days.
So I have, sorry, Dave has a question.
Hey, Jeff, Dave Skaggs.
Hey, Dave.
With the Acumed bone graft harvester, I take care of a lot of elite gymnasts. So you could take that, 8 to 10 millimeters within the cortex of the iliac crest. Post-op, they don't even know which side I took graft from. It seems like there's very little downside. Any thoughts on that?
I haven't used it. I know that there's some harvesters out there, and certainly if they could decrease the donor site morbidity, that's a great source of graft. I mean, autograft still, I think, is the best substitute. Well, I guess substitute's not the word, but I think it's the best graft material.
Quick question.
Yeah, question by Kojo.
No, on behalf of one of our attendants on Zoom, it's a direct question as to what options should be used in patients with metastatic disease that undergo posterior anterior fixation.
So metastatic disease, did you hear it, Jeff? What grafts should be used for metastatic disease patients?
Yeah, I think in that situation, I think you use what you have available. I don't think I would recommend use of BMP. I guess I'd worry about taking bone marrow from a second site if you're going to contaminate that site or something like that. There have been cases where I used bone marrow that I've taken, like I've started off and the first thing I did was like to do a percutaneous aspirate, and then I went to the site to sort of open the contaminated site.
So on that vein, for deformity surgeries, again, adults, not the Dave Skaggs pediatric population, the local graft, collecting that actually makes sense or not?
Oh, absolutely. I think that, there's the other thing that we talk about is volume. I mean, I pack as much volume as I can. That I think has some effect. And I think a lot of people don't think as much about volume, but I try to pack every nook and cranny. I also think that there's lost art form is placing it. Next time you do a CT scan posterior lateral and you look at your lumbar posterior lateral, look at the bone mass. And there, a lot of times I'll see the bone mass that's a little bit separated from the transverse process. And there's this great bone mass, but it's not touching the transverse process. Put the bone on the bone. At the end of the case, you don't have good retraction laterally. Your screws are in and it's hard to push the bone in. You're tired and you just want to go home. Take the extra time, take these retractors, then push the bone onto the bone. Bone can't jump a huge gap.
That's awesome. That's a great closing line. Thanks so much for joining. Bone can't jump. So,
all right, thanks.
Thank you, Jeff. Outstanding.